Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello, and welcome everyone. My name is Renee Garrett, and I am your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Cheryl Pelletier founded and owns NOSH Incorporated, feeding, swallowing services, and therapeutic dysphagia exercise tools, and receives compensation from its sale. She is also a Feed the Peds educational consultant. As a guest on this podcast, she does receive an honorarium from SpeechTherapyPD.com. Her non-financial disclosure is that Cheryl is a member of the Dysphagia Research Society, DRS, and an ASHA SIG 13 dysphagia member. My financial disclosures are that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia. I am also an adjunct instructor for both James Madison University and Old Dominion University. As the host of this podcast and other webinars on SpeechTherapyPD.com, I do receive financial reimbursement. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Cheryl Pelletier, MS, CCC, SLP, CLC, who attended Elmira College in New York to obtain a Bachelor of Science in Speech and Hearing Science, and then an MS in Speech Language Pathology at Northeastern University in Boston, Massachusetts. Her 37-year career has included being an ASHA certified speech language pathologist since 1987 and working with medically complex patients, including children and neurologically impaired, neurodevelopmentally divergent adults, neuro and oncology cases in acute care, home-based and outpatient clinic settings, co-treating with registered dietitians, PTs, and OTs. She has been a certified lactation counselor since 2008. She is the founder of NOSH Incorporated, a feeding, swallowing private practice, and creator of therapeutic chewing, swallowing exercise tools, the Side Biter and the Mini Biter. She has provided international educational seminars for NOSH Incorporated and Feed the Peds Company. She works in her private practice, providing feeding and dysphagia home care workshops and staff mentoring services. Welcome, Cheryl. So nice to have you tonight.
Well, thank you for having me tonight. It's very nice to meet you, and this should be a really nice chat.
Yeah, I think it'll be a great episode. So let's just start by kind of talking about your story and what happened to you and both your professional. I cannot talk today. Coming back from vacation, and I need a little assistance to get it all together.
That's okay. I'm a speech pathologist. Let's tap it out.
There you go. So, both personally and professionally, you had some situations that influenced your career path. So can you kind of talk us through how that transpired?
Yes. Well, I was actually the summer that I was going to go to Elmira College to become a speech pathologist, majoring in speech and hearing. My brother was hit by a car on his bicycle,
Oh,
and
wow.
he sustained a severe head injury. He was in a coma for 3.5 months. And when he woke up, he really had to learn everything. He was not talking, he was not walking, and he was not eating. I was a freshman at that time, undergrad, and I really didn't understand the whole gravity of it, but I watched it from the front row, how hard it was for him to chew and swallow, and he had a G tube. And from there, it really influenced me because I watched how hard it was for him. Starting, I think back in the day, they started with ice chips, and then a lot of it I only saw when I came home from breaks because I was in school. But I remember all of the struggles that he had with gagging and coughing and, not passing MBS and things like that. So that was a real eye-opening experience, and I never forgot it.
Yeah. Yeah, and it's crazy because they still use that word now, and it drives me crazy. The
I
pass or the
know,
fail.
I know, I know. And so you have to understand that when I did my CF, I was at Boston Medical, and my supervisor was actually her mentor was Jerry Logeman. That ages us a little bit back in when dysphagia was really starting to kind of come into play in our field. And I was very lucky to be mentored by such a woman who did a lot of research studies on people that had spinal cord injuries.
Mhm.
And she really proved that you could train somebody to swallow even if they couldn't feel. So it really made me very fearless in the dysphagia department early, like I was in my 20s. And I also was exposed to going into ICU suites when people were waking up from a coma, and they would send the speech pathologist in, I'm sure they still do, to alert them and get their mouth going and secretions. And there weren't a lot of tools that were very safe. We only had touthettes, and we had the lemon glycerin swabs and gauze,
Right. Yeah.
and I remember thinking, I wish I had something else. And that really stuck with me all through my career. And it just sort of is the reason why I started to invent some tools.
Well, the interesting thing is that I know people who still use the lemon glycerin swabs now, and I'm like, oh my God, please stop doing that.
Well, it used to scare me so much because when patients are confused and they're just waking up or they have a head injury and they really have that tonic clonic bite, and
Yeah.
you could lose a finger or the end of a lemon swab really quickly.
Yeah.
Um,
Well, and
so
I know that a lot of the talk back then was about sensory, and so I think that really lends us to talking about other, the way that tools developed. Because me coming in to the field about 15 years ago, I know there were still a lot of people who were using lemon glycerin swabs and like swore by them, and touthettes as oral care, which we all know that's not actually a thing. Touthettes, I think the best thing for them is to get the pocketed food out. That's really the best use. At least that's
right,
been my experience,
yeah,
is to get the
yeah.
pocketed food out
And
for
I
people
don't
who are.
usually use a lot of tools. That's the kind of thing is kind of weird, is that I use a lot of food modification and placement and positioning and cueing. But I felt like the last 10 years, my clients were more and more medically involved,
Mhm.
and they were really, I'm going to speak to some of the maybe older teenage and adult clients with developmental delay or new head injury, and the families were educated about the fact that they wanted this family member to get off a feeding tube.
Mhm.
And, it was really important to families to have the family member have actual food from the family table. according to the culture. And they were tired of puree, and they were pushing the clinician to do something. And even some of the cases that maybe were not appropriate to even wean, but maybe there were big events coming up, like a birthday or anniversary or a family reunion, and that person was MPO or on purees and, couldn't have the cake or a hot dog or something like that unless it was pureed for them. So that's the other reason that I thought, for quality of life, it would be great to have a tool that you could fill with food and it would keep the motivation going. There's so much depression that accompanies dysphagia, and patients give up and they get bored with our exercise regime. And I really wanted to have an alternative to what we had that was functional in terms of cueing a patient to maneuver their tongue, elevate their tongue, lateralize their tongue, get gradual flavors that might keep them going and facilitate frequent swallowing, so that the more frequently you swallow, the theory is the better you can swallow, and even help with secretions and allow the person to hold the tool if they could. If
Mhm.
they were able to, and with the help of an occupational therapist or physical therapist, be involved with their feeding and swallowing therapy.
So you started out in the adult inpatient world, correct?
I did. I worked many years in inpatient, and then when I changed jobs, the opening that was there, they wanted an eclectic therapist. They wanted somebody to see kids and adults. And
Mhm.
it was a small community hospital. I didn't have a choice. I had to do both, which I loved. I really loved the variety of it. In the morning, I would see kids, and in the afternoon, I would be on a spinal cord floor and I had an injury floor and go all over. And it was very challenging and very fun. There was some overlap in that, in terms of, kids, when they start growing teeth and they have a full mouth of teeth, they need the molar surfaces to be stimulated, and they need to get the idea about, when I move my jaw and my tongue and there's food in there, this is what I do. And, with the cognitive impairments that I was working with, it was very unsafe to give the families some home programs that would facilitate them eating more and more textures and amounts at home. Either the families wouldn't do it, or they did it and it didn't go well. So that was my other reason for inventing a tool that could be really utilized in virtual therapy as well as at home. So in 2018, I I I submitted a patent for this tool called the Side Biter. It's a 3-part tool. How my brain works is systematically. So can I show it just so I can explain it?
Yeah, sure.
Okay, all right. So what I'm talking about is the Side Biter chewing and swallowing system. Originally, it was created with a handle and 3 tips. And the 3 tips, this one is level 1, and there's 0 holes in it. There's no holes. You might see that it's the length of my finger. That's not an accident. That's because I was doing a lot of placement in people's mouths to try to facilitate tongue sweeping, elevation, and maneuvering and rotation. So it was designed for people that were MPO. And what I want, and it has a plunger, it's not a syringe. Basically, the plunger part holds the food inside of the biting part. This is a piece of apple in level 1 with 0 holes. People, I'm going to show you. So when it comes in the package, the plunger is like this. It doesn't really fit all the way in, and it does fit. It's just, it needs to be very tight so no foods or juices will escape out of the bottom. I really should have been an engineer sometimes because I was really wanting it to be a tool that could be used for sensory aversions as well.
Mhm.
I see adults that have sensory aversions either because of food trauma or gastritis. Here is an example of a case that really made me want to make these tools. This was a 37-year-old man with Down syndrome who had had severe gastritis and became fearful of swallowing. He wouldn't even swallow his saliva. Now, he had cognitive delays, also oral motor delays. Prior to this, he had soft solid diet, right? So he really wasn't a great chewer at the beginning. So he was one of my first clients I used a prototype with. And I started to say about the plunger, you need a little bit of oil that happens to be olive oil or food juices. For example, here's the apple. You put the apple juice or dip it in juice. The reason for that is because you want this to slide in really nicely and lock at the bottom, super important. So this has the apple in level 1, and I just want to show that you can see the apple really well, so that you can see what the patient's actually doing to the apple, and you can show them. You can say, Mr. Jones, look, you really crushed that apple. That was a great crush. Now let's do the other side. Or you have the apple, right here, and you can do some maneuvers with that. And maybe they're MPO and they're not allowed to have anything in the mouth at the moment, but they're going to salivate a lot. So level 2 has 5 holes in it. The reason I designed it that way is so that when a patient was chewing and swallowing under the care of a clinician, the most they could get is 5 mLs. So taking your data would be really helpful to talk about that you maybe brought a patient through level 1 with 0 holes as an exercise tool, went to level 2 with 5 holes, and level 3, this happens to have sweet potato inside. What I liked about the silicone, which is FDA approved and it can be boiled and frozen, is that you can see it really well as a patient. So if you have visual impairments and you use something like, I like sweet potato or raspberries, one of the cautions that I'll talk about later in my list of precautions is making sure that your patient can tolerate an ETSI level 5, which is kind of what comes out of here, but under the patient's own power. My idea was to make a bridge tool from puree to diced foods, but many clinicians have reached out to me and have said that they use things like avocado and banana, and it gave the patient an idea about, okay, I crush something and then food is in there, and then I have to do something and I have to activate a swallow, and they use their maneuvers and their cueing with gradual amounts of food. So the raspberry, I would be cautious of the seeds and the juice. You would make sure that whatever is in that side biter tool or any tool that you use, the patient would be safe. For example, I have a patient now that is not cleared for thin liquids, so I wouldn't use watermelon with this, or I wouldn't use oranges because it's very, very liquidy. I would use things that once it comes out, it would be safe for that patient. So I just wanted to get my sweet potato. So what I commonly do with patients is I give them an array of flavors to try. I have them communicate with me and they tell me what they'd like. So for example, I'm going to do this. I'm going to put some flavor of the sweet potato, and I might say, Okay, there's apple and sweet potato and steak. So you can use meats. The only things you can't really use are nuts and seeds because it would probably break through here. This has been out about 6 years and there's never been anybody that told me that it wore out. Most families will rotate through these. Say they might have a meatball in this one and then French toast in the other one. What I like about that is that the patient can use eye gaze or pointing or language to express what foods they'd like to participate with. And that's really powerful, especially when you're trying to learn to eat again. I use cheeses sometimes, like feta cheese or a real tangy cheddar cheese, to alert the mouth, to try to get a lot of salivation, to try to get motivation. And I use a lot of foods with color. I use butter. For example, I happen to have butter right here. And the reason that I like butter, if there's no food allergies or anything like that, butter is very flavorful and it goes with a lot of things and it helps the little plunger move and you can always refill it. There are clients there are therapists that reach out to me and they talked about how they kind of held this a little bit like a syringe so they wouldn't have to stop and refill it.
Mhm.
I don't do that because I really don't want any of the food and juices to come into the handle. I really want it to go into the mouth when there's compression on the tube. I use it without food a lot too because I like the length of it.
Mhm.
I often will guide, if the patient's holding it, I will guide this part and try to put it over and around in the mouth. I've used level 1 with the 0 holes for sustained lip closure like this
Mhm.
because I want the muscles of the lips and the facial muscles to work harder for straw sucking or to reduce drooling. So there's a lot of different things that I kind of come up with as I've gone. So I hope that answers that.
Yeah, well, and one of the things that, you've talked about, and I know I work with this population quite a bit, is developmentally delayed, particularly adults. So
Right.
some of the characteristics that we tend to see with that population, from anywhere from patients with MR to cerebral palsy to autism, or a lot of our intellectual and developmentally delayed patients that are adults have multiple comorbidities. So they've got a lot of the same diagnosis, like some of them have autism and MR, autism and
Right.
CP, or a combination of all three. And so we tend to sort of see this pattern of overstuffing,
Yep.
also tongue thrust, and then being, the caregivers are worried about aspiration risk, or even just choking, not necessarily aspiration, but like a true choking event because of the overstuffing and the rapid rate. And because a lot of these patients now that I see don't always have good dentition. And, because like the population I'm seeing right now for intellectually and I cannot say that word today, developmentally delayed patients, a lot of them range in age from anywhere from like 20 to 70. And we see a wide variety of dentition, oral care being poor throughout the lifespan, all that kind of stuff. And so thinking about it from that perspective, you mentioned sensory issues and a lot of times behavioral issues as well in this population. So I think it's interesting to see um how that's been used, and if there's any kind of like, if there's been any research that's been done to sort of help back that up.
So that's a great question. And I just want to summarize what ended up happening with that patient who had lost 52 pounds. And I wouldn't take the case until they got a G-tube for this man. He ended up being able to return to all of his previously eaten foods, but he had to start with level 1 because
Mhm.
there was a barrier there and he was afraid. So things like chili or pizza. And then we went to level 2 with the 5 holes. And I really had to talk him into, and with rewards a little bit about, okay, there's only 5 holes. Let's count them. There's 5 holes. And to show him that there was a little bit of food that was going to come out and that he needed to start to swallow. So he did really well with that. It took a very long time. It took 4 months. And because he essentially forgot how to chew. His cognition was quite low and he just didn't chew and swallow anymore. It had been a long time before they had come to see me. So there was data that I took on that one. And then I also had another patient who was in their 60s with Down syndrome who had a stroke. And they were very confused why they couldn't eat. And really, food was a big part of his life. So this was a great way to get him stronger and to get him back able to chew and swallow and activate a swallow on time. That particular gentleman, his swallow activation was very slow. He would chew and chew and chew and chew. And so it was a great way to get him to speed up his activation so that he could be safe. I have observational data. What was, patients and families and clinicians from across the world, Australia, Athens, Malta, Norway, Puerto Rico, they all report excellent gains with using this type of tool. It's not for all people. It's not for all patients. But what was around for us, I used silicone straws a lot. And why did we use silicone straws? Because we were trying to get the apple over here, right? Well, some of our patients, if they bite down on this silicone straw, it's going to eject into the back of the pharynx. And we don't want that. And for years, I was folding silicone straws and putting holes in them. And I was using chewy tubes, and there's nothing wrong with chewy tubes. I use them every day, a million times a day. I own every single chewy tube. But I needed something that could encapsulate steak or sweet potato. I needed something that was going to be bouncy, durable, facilitate independence. And a lot of it is common sense. Like this is all common sense. Then I came out with the mini biter. The mini biter is half the size and it has 6 holes in it. It was designed for patients with a very small mouth. There's a lot of syndromes and things that occur. I mean, I have right now in my caseload a 10-year-old that has a certain syndrome, and if it has an extremely small body, and really, I mean, you could do this. I've done this and, put it in the mouth because I didn't want to lose my finger. So you can bend it. I guess, to research it is super hard because how do you get a group that is the same and has the same goals? And I just came out with this because I really needed it. I wanted it for myself. And I think I told you, Renee, that I reached out to at least 6 companies. And I said, I have an idea. Can you take this idea and make it? Because I want it really bad. And companies don't take third-party ideas, even if you sign, an NDA or whatever, but I just decided that I was going to make it myself. And it's, with what tools people have been using, I thought it was a better choice for certain patients. I really like using it frozen. I will freeze like diced peaches or mangoes in there, or Greek yogurt. And there's videos on my website about how to do that, and on Instagram, side_biter. But it was really great because patients have to work really hard to get a frozen item out of these biters. And for a home program, and say you're only seeing this person once a month or twice a month because of travel or transportation, they are going to do so many things that they wouldn't do if they didn't have this. And it happened a lot with me where I would say, Mrs. Smith, you can eat whatever you want in level 2. And it's not a feeder, it's an exerciser. And I would write it out and she would have her G-tube or whatever. So the family would come back and this patient was eating eggs. I mean, it's only 5 mLs. So, if there's reduced stamina, then you would write a program for, chew and swallow soft solids for 10 minutes, 3 times a day, and make it so it's like associated with a meal. I did a big post on Instagram at Thanksgiving about how you could increase somebody's participation in Thanksgiving by using the side biter tools. Well, stuffing, believe me, I've chewed a lot of food in these things because I want to know how they act. Like, I'm
Yeah,
like,
sure.
okay, shrimp. I put a shrimp in there, put a scallop in there. How does it move? What does it do? What does it require of you? So when I do a lot of free staff in services. I offer that for everybody that purchases one. The cost is minimal on these. They're really close to my cost because I made them to help people. I didn't make them to make a lot of money. So when people buy them, I send them an email and I describe that I can provide free support at any time. I never charge. I do a virtual and it's been so fun. I did one in Australia. I got up at 4:00 in the morning and there was 55 clinicians and it was 7:00 p.m. their time and it was 5 a.m. my time. And it was so fun. So they gave me cases and we reviewed them and I gave examples of how I would use it. And I use it and I model it. Like I might say, look, I want to show you how this apple is, or I want to show you how this sweet potato, watch. So
Yeah.
see how it comes out? Oh, that's very buttery.
Dinner.
Because of course we want to, and in the same session, I've used that and then provided strips of the same food. I'm just taking the skin off of this apple because we want the strips, right? We want molar contact. We want crushing. But if I'm too nervous to put, if they're only on puree or only on liquid, which puree is liquid, this would be a great opportunity to even explore table food flavors. Some of the children that I saw at my hospital job, they had scenarios like this. They were born weighing a pound 15 years ago, which was very, I think we have better medical care now, but survived. And now they're 15 years old and they've had a G-tube their whole life, but they suddenly went to a physiatrist that said, why don't you go to feeding and swallowing? Yep. Okay. So you haven't ever chewed anything, and chewing on an empty plastic tube doesn't equate to paninis. It doesn't equate to pizza. So that is one of my reasons why I wanted to have something that would have true flavor. So baby foods, have you ever had baby food bananas? When you compare it to a fresh banana that you might put in a food mill, or my favorite thing in the world, I love graters because I grate a lot of foods and I break them down and then gradually we build them up, right? A fresh banana is totally different nutritionally as
And
well
taste.
as taste. I
Yeah.
think I have an aversion of bananas in the jar. When it opens, I'm like, and our patients that gag, or like you mentioned, the autistic population that they only eat 3 foods, and it's difficult to transition to other foods. I've used this a lot. Just the other day, I used this with grapes, grapes are traditionally quite dangerous, especially if, they squirt and they have skin and whatever. The family usually presents me with 2 or 3 foods that they would like their loved one to eat. Grapes was one of them. I put grapes in mine, and I was just saying, oh, my grape is so juicy, and I'm chewing away. And I noticed it was squeaking a little, like squeak, squeak, squeak. And I said, oh, I'm just squeaking my grape. I was hanging out, and the young man who's 17 was like so enthralled with the noise, and he wanted to squeak. So I was
Yeah.
like, okay, what do you want to squeak? Do you want to squeak a meatball in your mouth or grapes? And he ended up getting the taste, enjoying the taste. Now, he had oral motor delay, not pharyngeal phase dysphagia, but he had rigidity, so he wouldn't ever put anything in his mouth. So that was a big deal, that he actually put something in his mouth that had flavor. And from there, we did pea-sized amounts of grapes and placement with a straw, which I still use. And we graduated to raspberries. But we did a little bit at a time. And I think we ended up doing the mini because he selected it. I was like, do you want a little squeak or a big squeak? And he picked it, and I went with it. And I mean, I had been working with him for 7 months. So it wasn't like, ta-da, you get to do this. So, consistency and experience and interaction with something that is functional is what I wanted. So that's
Right.
kind of my story. As far as research, super hard. I mean, I've had, like, the University of Utah actually reached out to me, and they were going to do, like, I don't even know how to describe it. They wanted to figure out how much pressure it would take to crush one of these. And then, I have no idea, but I know that when I put it in my mouth, it feels really natural, and it lends itself to be either empty, or I also use it as a tool. I will stir like something. I will stir, pizza sauce or pudding or something like that. When I have kids or adults that have spoon aversions, I might use that instead of a spoon if they were traumatized with somebody trying to, feed them. And then I have used it for pocketing a lot. I will have them even use it empty. And I know they have a wad of granola bar or chicken nugget in there to try to move it. And I'll
Yeah.
use a mirror and say, oh, I see you have chicken coming out. Where did that come from? So I try to use it that way.
Are you taking advantage of our new amazing feature? The Certificate Tracker. The free CE Tracker allows you to keep track of all of your CEUs, whether they are earned with us at speechtherapypd.com or through another provider. Simply upload your certificate to your registered account and you're all set. So come join the fastest growing CE provider, speechtherapypd.com.
So the next thing I wanted to ask you is kind of a two-part question, because you mentioned diet level that you prefer or that the patient needs to be tolerant of. So where do instrumentals play into this prior to the use, during the use, to sort of monitor and see where people are? Because obviously if we're concerned, anytime we're concerned about someone who hasn't been feeding and swallowing for multiple years, then we would be concerned about oral care and the aspiration risk. But where do instrumentals fit into this as far as, where
Oh,
do you?
absolutely. Prior to any use of any technique or tool, you would do a complete dysphagia and feeding evaluation, detailed. And if there were any red flags to the clinician, that there was any kind of history of respiratory problems. Some of the patients I've had, they don't even have the skills to participate in an instrumental. So I feel really strongly that their first meal should not be barium. And you want to try to, with your clinical observation and skills, to see if the pattern of their oral movement and swallowing activation could lend itself to an instrumental, and, a medical workup to see if there's any involvement. That's the thing, is that I've sent people for instrumentals and they don't do anything because they don't know what to do yet. So I kind of teach to the test, like, okay, I hope to get you to puree and then to a dissolvable, which brings me to my Ritz cracker over here. So dissolvables can also be crushed and used in this, and it's very audible. It makes a noise. And, rather than putting a big chunk in somebody's mouth, or a cheese puff, or, a veggie straw, I like to go very gradually and, like I said, grate it or offer it in level 2, which would be very scant amount of food that would enter the mouth. So once a complete dysphagia evaluation was completed, and kind of the level that they're at. So I'm just going to hypothetically say, okay, they're cleared for thickened liquids and they're cleared for puree, and you're trying to advance them to soft solids. That's where I personally was having a struggle with people getting so discouraged that, okay, we're just pureeing everything. But what if this patient, and again, it's not for everyone, but what if this patient was able to essentially puree their own food in the side biter? So let's say a muffin or a birthday cake, which a birthday cake, when you chomp on it with the side biter, becomes a puree. It comes out like a puree. It mixes with the saliva. And then like something like chicken would be more of an Etsy level 5. It's minced and moist, but it's under the power of your client. You didn't have to fork mash it. I mean, you could fork mash it and put it in the biter, but the point is that it's not really a feeder. It's a way to get some motivating flavors and experience sensory wise, and to understand what it would take to bite into an apple. But it would be in a strip. And so say they're on applesauce for a really long time, then I might grate it, and then I might offer it in the side biter, because I want them to feel the thickness of it and the firmness of the apple, and what strength that takes to mash it. So many of my older patients post-stroke, they would, you would give them a strip of something and they would kind of gum it. They would be like, so there wasn't even, the masseter muscle wasn't even really moving. But if you could see it without losing the food in the mouth, because once it's in there, it's really hard for the clinician to gauge what they're doing, because you can't see. And so when I have a lot of colleagues, and some of my colleagues use gauze still, they wrap the apple in the gauze, and that's fine. It's, a sham bolus or whatever they call it, but you can't send that home with somebody. It's not safe. And I don't know about you, but have you ever chewed on gauze before?
I mean, only when I have like my wisdom teeth out. That's
You're right.
gross.
But there's people that have talked to me that say, why should I have this tool when I just can use gauze? And I'm like, well, that's good, but it doesn't taste good. And it's kind of makes like this, you can't taste the plastic or anything. You only taste the food. So I hope that answered your question.
Yeah, and I was thinking about, even like with fees, because I know when I worked at inpatient rehab, I did fees on all kinds of people. patients with pretty significant TBIs, patients with dementia, Parkinson's, ALS. I've climbed into a bariatric bed and an LTAC before and done a fees. And so, again, I'm just thinking about like I get what you're saying about having like you don't want their first meal to be barium. But, from an instrumental assessment, we really need that piece of data
Yes,
too, because we
you
we
do.
do worry. Yeah. And especially again, I go back to IDD patients and dementia patients because depending on who the caregiver is and depending on their level of cognitive abilities and their ability to physically complete oral care, we know that, those three pillars of pneumonia kind of play
Yeah,
into all that, mobility and comorbidities and oral care and what else is going on. So I just think that that's a good point to make too, because I think
yeah,
this sounds like it has a good, I like the sensory component of it for a variety of patients.
yeah.
Um,
So
but I think
absolutely, you
I don't
could.
want people to like come away and think that this is like a one trick pony, I guess is what I'm getting at.
No, no, and it is not for all patients. Like I'll go months and months and months and not even use it because it's for specific things and it requires a skilled clinician to come up with the strategies that they want to use and the goals that they want to achieve. But absolutely doing the fees and doing any kind of instrumental is ideal to know exactly where the level of the patient is prior to any treatment and any tool. Absolutely. I was thinking also about the younger population that they've never eaten before. So it's a little
Yeah.
bit different if you've eaten before and then now you have dementia and a stroke. You have something in your head and you've had that experience. Some of the younger folks that I've worked with, they really don't have that blueprint in their brain yet. So that's why I was saying that I try to teach them to chew and swallow or swallow secretions or swallow before, well, while we're waiting for the instrumental. It's
Yeah,
not
because let's be
holding them
honest,
back. It's not that
that
I'm holding them
sometimes,
back. Yes, exactly. There's a wait list. There's always like, a 2 to 3 month wait list. So I wouldn't just say, okay, I'll see you in 3 months after you've had your instrumental test. So and I wanted to, before I forget, this is a tool that's really designed, or tools designed for people that are rehabable. I wouldn't use it with ALS or any other very degenerative disease because you don't want to tax their system and use the available energy that they have for talking and eating. It's not going to make them better. I would use it for people that really have prognosis to improve. Does that make
gotcha.
sense?
Okay. Oh yeah, yeah. Because I was thinking, like in my patients I've had with myasthenia gravis, where we know that fatigue is a huge barrier, and a lot of times if we're trying to do any sort of swallowing or dysphagia exercise program, we have to sort of gauge their ability to breathe and their ability to participate. There's some other diseases, where pain is a barrier, and if what we do increases the level of pain, that's going to decrease the motivation for the patient. So I think that's
Absolutely.
an
Yep.
excellent point.
So one of the types of patients I've been using it with lately is oncology patients, people with oral cancer, because they've been radiated and they have thickness and they have poor agility and they've had some oral sores. This has been great because you can put it in the back and really facilitate some more movement when maybe they weren't able to eat for some months and they were able to do some tastes of table foods safely, which was wonderful. Again, it's not a feeder, it's not something like a glossectomy device or anything, but I just had a patient wean from a G tube with using this in conjunction with food modification because the stamina of the jaw was so poor. I had surgery and a lot of just stiffness, pain and stiffness, and poor range of motion. So that was real, and it gave him a lot of hope because we're coming into, July 4th, and he was like, I just want to have a cheeseburger. So I graded it. So what I did was I used my grater and I graded the cheeseburger, broke it up so he wouldn't have to work so hard with level 3. Remember, level 3 has 5 holes, 10 holes. The difference between level 2 and 3 is the rate of flow. So level 2 flows slower than level 3. Level 3 has the 10 holes, and the food can come out of both sides. So that was really helpful. Remember, level 1 has no flow. So it's zero flow, slow flow, and then faster flow. And it was short term. These are not designed to use for 10 years. They're designed in a rehab situation. And I got a letter from a chef, actually, that got hit by a car while he was on a moped. And he had a massive head injury. He was a chef and he was a foodie. And his fiance wrote to me and said, you can't believe this man, how upset he was that he could not eat when he woke up. So they were putting things like truffle fries in there, and I don't even know, filet mignon. And he was so motivated that he really did such a great job. And I don't know, I don't have any research on that, but I can tell you that if I couldn't swallow, I would want something that gave me a sense that I was getting better by chewing, pineapple upside down cake or something.
One of my former bosses is a PTA by trade, and she would always say, if I have a stroke, PT can get the heck out of my room. I want speech and OT because I want to be able to go to the bathroom and I want to be able to eat. And I thought that was so funny since she was from the physical therapy world. But I think two other really important things, some precautions that you had kind of sent me beforehand. Can you talk about supervision of the patient with this?
Oh, absolutely. This is designed for 100% supervision, because I work with kids at times. I say, do not give it in the car. So number 1, instrumental full dysphagia eval. Number 2, making sure you understand what they're cleared for. Staying away from liquids and seeds and skins if that's something that they can't do. The third thing or so that we talked about was not to be used with degenerative diseases. Just be cautious of what you're asking them to be doing. We don't want to use calories doing something that's not going to help them actually get calories. And we want 100% supervision. This is a therapeutic tool. You can write, or I write home programs, and I do a video on the phone about how to use it. And I supervise them and make sure that the caregiver is supervising the patient. The plastic can't come apart. Like, you can't pull it apart. It's one piece. So that's a good thing. And making sure that you're not frustrating the patient, making sure that it's something that they are enjoying using, and that the flavors make sense and go along with their culture, making sure that the family understands that this is an exercise tool and not a feeder. And it's used for individual patients. It can be sanitized in boiling water, and it can withstand 500 degrees. You could actually bake in it. It's kind of like the silicone baking things that you can get.
Yeah.
However, I don't recommend, using it across patients, especially post-COVID. So that's, and what I do is I have a demo. In fact, this one says demo on it. I have one so I can show caregivers and patients how it's used. I wouldn't just stick it in somebody's mouth or hand it to them. I would explain what we're doing with the tongue and lips and jaw and the swallow activation. And it's dishwasher safe. So it can be sanitized quite nicely in the home environment. It does come with its own scrub brush, which I don't know where it went, but it's a specially designed scrub brush that you can get like mac and cheese out of it and things like that. Each package comes with its own scrub brush. It comes separate or it comes in the kit. And I don't know what happened to my scrub brush, but anyways, there's a special scrub brush in there. I think it rolled off of my table because I have so much stuff. I'm just gonna open it so you can see, but basically, it's nothing comes from abroad or overseas. Everything is from America, which costs a lot more. These doubled in 5 years. These doubled in
I'm
5 years, which I was really upset because I wanted, so the fan tip is key because I wanted it to, get all the particles out prior to soap and water. See how it fits in there good. I didn't want anything to be, contaminated with this. Oh, speaking of that, it was designed to stand up.
Mhm.
So if you're in a facility or in someone's home, not only does it facilitate grabbing for motorically involved people, OTs love it, by the way, because of that, but it doesn't fall over and get contaminated and roll around on a table.
Yeah, that's especially in a facility, because my number one pet peeve was always seeing the lunch tray come in with the urinal sitting next to it on the tray table, and you're just like, "Oh
Yes,
my god." Or
yes. So
someone left a alcohol swab from a blood draw sitting on the table, and you're just like, "Ah, ugh, stop it."
right. So I really felt strongly that I wanted each tool to stand up. And people have asked me why it's green. It's because it's on, this looks like it's Kelly green, but it's really not. It's more like a spinach color or a green bean color because I wanted it to be a food color.
Mhm.
And then this is also a food color, the color of corn or squash or a banana or whatever. So I really felt strongly because some of the patients I've seen in my past had so many aversions, phagophobia and other things, that nothing green went near their face. So I was like, I'm getting it green.
No, and that makes sense because again, when we're looking at things that, you know, everything right now, I think and in a good way, the best way possible, evidence-based practice and
Yeah,
research-driven practice, and that's great. But sometimes I think the sensory piece gets left out, or maybe not as paid as much attention to. And I think when you've worked in a lot of different settings and you've worked with a lot of variety of patients across the lifespan, you do see that importance. And one of the things I think it kind of took my mind to was our patients who maybe do have a degenerative disease when it comes to quality of life.
right,
So maybe they're not rehabable in the sense, and I know you said it's not a feeder, but I could see that there's potential and maybe even a research basis for patients who want that quality of life.
right.
And I'll kind of tell you where my mind went. I had a patient that had laryngeal cancer, and she had had a tube for a while, and she was only like 42. She had three little kids at home, and her husband was a physician. She was great. She came in every few months for I call it the tune up, and just the hopes that she could have a rehabable swallow. And I think at this point, she was over 5 years post surgery and post all the radiation and chemo and everything. And while her cancer had been put into remission, she was still really struggling because she wanted to be able to eat. And so I could see that for her, that might be something that could have been helpful. And I'll tell you the funny part of that story, because sometimes I think again we get these cases and these stories, and it's really challenging for us as clinicians to see it and know that sometimes we are not going to be able to get this patient back where they want to be, particularly in those younger cases like that. But she said she had a dietitian. All she wanted was a glass of red wine. So what she wanted to do was her husband and her wanted to have a glass of wine on their anniversary. And so she told her dietitian, and her dietitian said, "Well, you can put that in your tube." And she said, "I didn't think about the fact that and she's a teeny tiny little petite lady anyway. And she said, "I just poured it in my tube. I didn't even think that I should, maybe bolus it or whatever." And she was like, "I was college drunk," is what she said.
Oh my
But for
God.
her, to be able to maybe not even to have like the one with the holes, but just the one where she could dip it and then
Yeah.
have that taste, could
Right.
possibly.
And people have told me that they've used it, and I think it's the clinical judgment. I haven't written, an extensive recipe book for how to use it. And the reason I don't is because I think that clinicians are so creative, and I want them to use, think about it, like what you were saying, quality of life. Okay, you can have your birthday cake. Or how about, I have a family that I work with now that they bring the biters with them, and when they go out to dinner, they don't have to puree stuff. They can put a French fry in, and they can put fish and chips or whatever, and the person with them, their loved one, can participate. And carrot cake with without the nuts. They got it without nuts because he has a nut allergy. And the person was so happy. And there's something to be said about, food. That's why we love food, because it tastes so good.
Mm-hmm. Well, and it's a experience for a lot of
It's
people.
a social experience. Exactly.
Yeah. Yeah. Well, I just appreciate you coming on, and I think this is a little bit probably out of the box for a lot of people. And I think sometimes out of the box is good because it gets you thinking, it gets you looking into sort of those things that are more functional for patients that can promote quality of life. And
Right.
and just, anytime I can help facilitate a clinician learning something new or just experiencing something new, whether they agree with it or not, I think is always a plus.
Correct. And keeping your mind open is really good. There was a mom that called me. Her 27-year-old son had a seizure disorder and was doing really well on soft solids, and then had a bunch of seizures and then stopped eating altogether. So going through the levels of the side biter, and again, patients don't have to go through the levels. You can just start at any level that you assess your patient at. But that's how he learned to eat again. He just
Yeah.
needed to, he was unsafe to put like French toast in his mouth. But if he had it in level 2 or 3, he kind of brought back the memory of, oh yeah, I love French toast. I forgot. Because of the seizures, he had lost some skills.
Yep.
Okay.
So thank you so much.
Well, thank you so much for having me. And
Yeah.
I'm a little bit different than some of the clinicians that probably are watching, because I see children and adults. I'm kind of a unicorn.
Unicorns are good. We like unicorns.
Yes.
Thanks again, Cheryl. I appreciate you being here. So thanks again, and we look forward to seeing you.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Each episode comes with an accompanying course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code BRAINSTORMS20. SpeechTherapyPD.com is run by SLPs for SLPs. We've got the largest library of ASHA CEU eligible courses out there, adding fresh content every week. Remember, use BRAINSTORMS20 to get $20 off access to over 1,000 courses for an entire year. Head over to SpeechTherapyPD.com for more information and start earning CEs today. Thanks for tuning in to Brainstorms, Functional Neuro Rehab for SLPs. And don't forget, SpeechTherapyPD.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us. We'd love for you to drop us a quick review and hit that follow button.